You are live now. Then you can start. Can you please just tilt your screen to portrait so that it can be bigger?
Yeah, I've done that. Can
Perfect.
you see? All right, thank you. That's weird. Anyway, thank you very much. Okay, can you hear me? Hello?
Hello, yes, we can, Dr.
Yes,
Maria.
All right. Apologies.
Okay, I think you can go ahead. It's 12 past.
All right. Apologies. Good evening, everybody. I'm going to be sharing on hysteroscopic metroplasty. It's very simple. It's a very straightforward presentation of something that I've not yet done. I'm hoping that we'll learn one or two things. In case I've got a case that I hope that we'll all be able to contribute to at the end of the talk. I've got a terrible flu, so bear with me. My voice is almost gone. So as an introduction, I'm just going to go over the outline, give definitions of what metroplasty is. Are there any indications for it? Then I'll just quickly go into my case and try and summarize it. I'll briefly touch on the techniques that we can use for metroplasty, and then we can discuss. So metroplasty is a reconstructive type of reconstructive surgery used to repair congenital anomalies of the uterus, in which case today we are just zeroing in on septate uterus. The surgery entails removing the abnormal tissue that actually separates the cornea of the uterus, then using several layers of stitches to create a normal shape of the uterine cavity. This is the sort of like traditional way of trying to reconstruct the uterine cavity. Also known as the Strassman metroplasty, uteroplasty, or hysteroplasty. All these are synonyms for metroplasty. So historically, the septum removal was actually performed via laparotomy. And so it's via the Jones or the Tompkins procedures, which involved excising a wedge of the uterine fundus with the septum in it, or opening the fundus and incising the septum. And then this wedge incision would then be repaired by several layers of stitches. And of course, you know, with a laparotomy, you'd have to be admitted, undergo the downtime with your major surgery, and of course, then have the risk of getting adhesions after. Sorry, after. Did you lose my screen? Hello?
Yes, we have lost the screen, Dr. Maria.
Dr. Chamyonga, can you phone Dr. Mateveki and ask him to look for an anesthetist?
Okay, it's okay.
Thanks. He's trying to phone me. That's why I lost the screen. Sorry, guys.
All right, it's fine.
Okay, I'm going back now. Okay, screen is on. So what are some of the indications? So basically we can use this type of treatment to evaluate and can be part of treatment for a woman who has recurrent pregnancy loss due to the uterine septum. So what is to remember is that even when a patient has a uterine septum, it is always best to evaluate all the other systems and exclude any other reasons why she could be having recurrent pregnancy losses or recurrent preterm birth, for example. Because then you can remove the septum and then realize in the future pregnancy that she still miscarries. So better for it to be the final thing that you do in that evaluation. So this is just a diagram just to remind us of what a septate uterus looks like. There's something there. Can you see it? So this is basically coming from the embryology of the uterus. You know that the genital tract has got two sources, so the Mullerian ducts and the urogenital sinus. So they'll come together, fuse in the middle, and then that midline septum should be resorbed with time. So if that septum remains, so this is basically a normal uterus, so there's just that septum that remains. But remember that the septum can be just uterine, can be very small, can actually extend all the way to the cervix, and sometimes really can actually be found as well in the vagina. So it's part of the assessment as you do before you start treating the septum, to just make sure that you're clear of the anatomy. So this, if you're to do hysteroscopy as part of evaluation, this is what you would see, number 4-5. So you can actually see the uterine cavity is divided into two, and you can see the septum in the midline. Then if you go through on each side, you should be able to see the tubal ostia, one tubal ostia on either side. So that would confirm that it's a septum. And then if you had to do other investigations like a hysterosalpingogram, MRI, and then you could actually see that abnormality there to see that there is a septum dividing. So not to be confused with the biconate uterus, in which case, whatever we're discussing today does not apply for a biconate uterus. You cannot do what we're discussing today for a biconate uterus. Hence the importance of you doing a thorough check with the anatomy survey to be sure. So I'll go ahead and present the case of a lady doctor that I took care of this, in fact, for the past 5 or 6 years, but we managed to achieve a live birth this year. So she first came to my rooms when she was just recently qualified. She was about 25, and she had recurrent yeast infections, abnormal uterine bleeding, and she had some symptoms that alluded to a possibility of PCOS. So we did the workup, hormone assays, did a scan. Her bleeding was a bit abnormal, so she would bleed, and then after a while, so you stop the period. Then after 2-3 days, he sort of like sees dark old blood coming out. So that prompted us to just do an anatomy survey. We did a scan, and the scan said that she had a biconate uterus back then. So we thought she had a biconate uterus, but she was not yet sexually active. She didn't even have a partner. But the main reason was coming for irregular periods and for the recurrent yeast infection. So with time, she then got married, and then she started trying to have a baby. And over 2020 and 2021, she actually conceived on Clomid twice, and the 2 consecutive first trimester miscarriages around 10 weeks. And then we managed them medically. So at that point, I then said to her, why don't we just go and evaluate further and perhaps do a hysteroscopy and see what the anatomy inside the uterine cavity says. So we then did an MRI, which confirmed that she had a septate uterus. And at that point, that's the MRI report. The MRI showed that she actually had 2 endometrial cavities on either side of the septum, each measuring 8 millimeters in length. Then, of course, they noted the multiple follicles. So at the end, they said she had a septum which was about almost a centimeter. That's what they reported on the MRI. So she then just disappeared, and we didn't do much about it, only for her to come back to the clinic last year pregnant. So she prescribed herself with Clomid, and she conceived twins. So she actually came to the clinic when she was already 8 weeks, with the scan confirming that she had dichorionic diamniotic twins. And the scan already said she had a biconate uterus, and the twins were in the separate, what they call separate ones. So they thought she had a biconate. So she started bleeding around that time. And then we put her on progesterone, which didn't really help much. She continued to bleed. And then I canceled her on the high risk of just losing that pregnancy. So at that point, I then decided to work with the fetal maternal unit. And I asked Dr. Veringa to just do a detailed scan to just confirm the anatomy for us and to see what was going on. So she then ended up going to Dr. Veringa around between 11 and 12 weeks. At that point, she had a scan, was cancelled, and was noted to have a high risk for preeclampsia. So he then commenced her on aspirin, and an aspirin for high risk for preeclampsia. The bleeding worsened, and then she went back for a scan, I think about a week later, and the scan confirmed that she had actually lost 1 twin. So at that point, we thought that she was just going to miscarry both twins, but she carried on bleeding. We didn't stop the progesterone. At that point, I stopped her from going to work. She was just at home. So she continued to bleed. And then 2 weeks later, we did a scan and found actually that the other twin was surviving. So we then carried on with the remaining twin in the one. She bled until about 23 weeks. And then, unfortunately, around 26 weeks, she developed severe gestational diabetes, noted with the dramatic macrosomia that we noted during our routine growth scans, with a massive polyhydramnios, and the baby was in breech position. So I cancelled her. Now I was worried about the risk of rupture and everything. But she was very motivated. She said, no, doc, I'm going to have this child. So again, I looked for another team to assist. And then I spoke to the endocrinologist to try and help because the sugars were poorly controlled. She was actually ranging. In fact, the sugars were all above 20 each time she measured them. So I was now worried. Oh, sorry. I was now worried that she was actually just going to lose the pregnancy, just have an IUFD. So we worked with Dr. Zaranyika and he managed to control the sugars. But during the whole course of the pregnancy, she had recurrent yeast infections and blood infections. So she was on either antifungals or antibiotics the whole time. So she managed to proceed to about 34 weeks.
Is it me or
And
everyone
then we
can't hear
started
Dr. Maria?
discussing dexamethasone because we didn't lose.
Okay. You can't see your screen, Dr. Maria.
Hello. I think my network just dropped there. Can you hear me?
Now we can hear you, but we can't see your slides.
All right. So we then proceeded with the dexamethasone. And
We
whilst she was
can't
on
see
the
your
ward,
slides, Dr. Maria.
can you see them now?
No.
Oh. And now? Can you see
No.
them now? Okay, let me try again. Can you see them now?
No, we can't, Dr. Maria.
Mm. It's the interruption I'm getting with the. Let me try again. Can you see anything on the screen? Nothing. Hello?
Nothing.
Nothing.
We can't. I mean, you may have to proceed, Dr. Marera. I don't know about others. You may have to proceed without showing us the presentation.
Dr. Marere, you are muted.
Can you hear me, Doc?
Yes, now we can hear you.
Okay. Just going to try
I
and go
think
back.
I think just
I'll proceed.
just speak.
Okay. Can you see anything though? I've put the pictures.
Just
You
speak.
didn't
We can't see anything. We can't see anything. I think just speak.
All right. So we did a C-section. Then I noted that she just had a very slight indentation on the fundus. And then when I palpated post-delivery of the placenta, she actually had a septum that was coming all the way down to the lower segment of the uterus, basically. So it was about 5-7 centimeters in length, but this was just post-delivery. So yeah, I think maybe I can just pause here briefly. If there are any questions pertaining to the case, then I'll proceed. Hello? Can I proceed?
I don't have a question. I think it's a really interesting case. I think if there are no questions, you can proceed.
All right. So So basically, where we are with this patient is that she is keen to have more children in the near future. And I just discussed with the possibility of us removing the septum if it's going to be of any benefit. So perhaps we can comment right at the end. So I'm just going to go ahead and discuss metroplasty and some of the techniques that we can use. So like I said, with the older technique, it was the laparotomy basically with this morbidity, risk of adhesions, infections. And of course, after you'd gone through the whole myometrium, you'd have to do a C-section for any future pregnancies for that woman. So hysteroscopy, the advent of hysteroscopy has actually allowed effective transcervical correction of this abnormality. And in this case, we said we have to make sure that the anomaly is actually is not a bicornuate uterus. MRI may be useful as you try and wake up the patient. So the good thing is with many septa, they actually require incision rather than excision as part of the treatment, or how you actually lyse that septum. So with the incision techniques, you can use laser, you can use even a cold scissors, you can use a knife or point electrodes, you can use a resectoscope where you resect. And of course, each one has got its own pros and cons. No one method, according to studies, well, very small studies done, is superior to any. So you can choose whatever you're most comfortable with. But to remember that if you're going to use a resectoscope, because the septum will be looking at you, you will be having to go the opposite way. So you're actually using the resectoscope in a forward manner, in which case it may be difficult now to determine whether you have reached the fundus or how far into the fundal, into the myometrium you have gone. So other authors have suggested that you can actually use laparoscopy as your guide. So you can lower your intensity on the laparoscope and then see as you are resecting. If you're now really transilluminating through the myometrium, then you know that you've taken a big chunk of the myometrium, then you can stop before you perforate, because the real risk there is just to perforate right through. And of course, we know that once you've had a perforation, you need to do laparoscopy, especially where you're using energy. Do laparoscopy to check for inadvertent injury to surrounding structures, especially bowel. So at surgery, you identify the extent of the septum, evaluate the two uterine cavities, like I said, identifying that there's two ostia, one ostia in each cavity. If there is a vaginal septum, rather deal with the vaginal septum first, and then later on do the hysteroscopy for the uterine septum. And then you can use the laparoscopy as your guide. At the incision stage, when you're actually now doing the incision, notice as you just cut, for example, with the cold scissors. I'll try and share a video right at the end. Now I don't know if it will show. Notice the cavity starts to open up just as you incise the septum. Try and stay in the midline, cutting small bits at a time. The good thing with the septum is that it's just fibrous tissue. So it actually doesn't bleed, especially if you just stay in the center and not go either too anterior or too posterior, it won't bleed. And then once the cavity becomes one, then you can actually stop. Try and avoid extending the incision into the uterine fundus, as this may actually weaken the uterine wall and lead to perforation or rupture in future pregnancies. Always try and exercise caution with the resectoscope. Remember, like I said, you'll be cutting forwards, which is a bit abnormal. So post-operatively, lots of things there. Attempts are there, of course, to try and reduce the formation of intrauterine adhesions after you've done that surgery inside the uterine cavity. There are very few studies that exist. So some have put across the use of antibiotics. I hope we'll share what we are doing in our practices. Antibiotics, some will put the copper T to try and reduce the chance of forming adhesions. Some will give a course of estrogens followed by progesterones after a month. So basically, I just took some evidence from this guy called, who is it? Norroth with his colleagues. They did case series and just looked at a small number of patients who underwent septal resection and were placed on different types of therapy post to just see if any were more superior. So some of them were actually put on HRT alone, some were the copper T inserted, some had cyclical hormone replacement therapy. But at the end, they noted that there was no significant difference, whatever thing was used post-operatively to try and reduce the adhesions forming post-op. So most people would go ahead and put their patients on estrogen for a month and then followed by progesterone for withdrawal bleed. Most patients actually do heal very well without any scarring. And the reproductive outcomes encouraging are also very, very good after removal of the septum. So I looked again at a series, where they looked at women that had miscarried or had delivered prematurely. And they noted that after hysteroscopic removal of the septum, 81% of patients achieved pregnancy, with 83% managing to actually deliver at term, 7% having had preterm births, and 12% with first trimester losses. Again, Homa and colleagues also evaluated a number of case series and still found that patients that had had a recurrent loss due to a septum and had had metroplasty also had improved outcomes. They managed to deliver at term. And the rate of recurrent loss or rate of miscarriage was reduced significantly. And then Lavin and his colleagues also did a retrospective evaluation of women with these abnormalities and noted a lower rate of implantation that actually improved once the septa was removed. So it's a small case series, but they did note that with septum lysis, the rates of implantation actually did improve. So therefore, for all IVF patients, it is recommended that they have uterine septa lysed before they're offered any treatments. Okay, so this is what I have for you. I wanted to share this video, but I'm not sure it's going to show. I don't know if there are any comments or questions. That's what I prepared for you today. Dr. Gwanzura. Hello.
Hello, Dr. Marie. Try to share your video.
Let me try.
In the meantime,
All right.
see. Then perhaps we'll be able to hear from
Okay.
the team.
Can you see my screen now?
Not yet. Not yet.
So it's not going to show. Let me try and send the link. Okay. In fact, okay, fine. Let me try and unshare and then start the process over again. Screen. Mhm. Okay. Can you see anything? Start broadcast. Okay. Now I go back to the presentation. Now I think we can see. Can you see that?
Yes, Dr.
Hello?
Marere, we can see it.
Okay.
We can see it.
All right. It's not going to show. Dr. Chamyonga, let me just see if I can share this link with you, then you can share it. It's refusing to play. But basically, it's just a video just showing how you just do a metroplasty via the vaginoscopy way of doing hysteroscopy. Introduce your scope into the vagina and then into the cervix, into the uterus. Do your survey, observe your septum, and then you just, this video was just showing you using a cold scissors to just cut bits until you get to the fundus where the cavity actually then just becomes one. I'll just share it later on, then we can just see. Otherwise, I think that's about it. I'll try and keep trying to share it. If it works, you'll see it now. Otherwise, in summary, hysteroscopic metroplasty is simple, relatively safe outpatient procedure that we can employ to improve reproductive outcomes in women, especially those that have recurrent pregnancy losses without any other indications. It's a common practice worldwide. We should also adopt and offer women with septate uterus who actually have subfertility, recurrent pregnancy loss, and preterm labor, and hope to improve their reproductive outcomes. Thank you.
Thank you, Dr. Marere. Stanley, please go ahead.
I can't hear.
You are muted, Stanley.
Sorry, I didn't hear that. Good evening, everyone. Thanks, Dr. Marere, for such a good presentation. I joined late. I was in London, so I joined late. So I wanted to find out about this patient, the one that you presented. Does he have another problem apart from the septum? And was he previously operated, or I don't know. So because I wanted to find out if there's any need for any further surgery now that she had a baby, and if she wants to get pregnant, doing the surgery, does it improve the pregnancy outcome in future?
So the only thing, okay. Thank you, Dr. Ngwaru. Can you hear me?
Yes, I can hear you.
Okay. So the only thing with this patient was that she had a medical condition, PCOS, and then turned out to have gestational diabetes. So it probably was pre-diabetic, although all the efforts to look for the diabetes were all negative before, because she is somebody who had recurrent infections all the time. So that's her background. She actually has polycystic ovary syndrome. And she had lost 2 pregnancies in the first trimester, with scans that were actually picking that she has a uterine abnormality. That's all she has.
Okay, thank you.
Hello, Dr. Marere.
Yes, Dr. Chamyong.
So do you think that the miscarriages were because of the septum or because of the comorbid condition?
Because now that's the discussion precisely, that she has 2 things going on at the same time. So initially, I just thought she had the septum was contributing to her early losses, but then with what then later on turned out to be other medical conditions in the background, it's difficult to say. What we never really looked for are things like antiphospholipid syndrome, the other things. The only thing that I know for sure is that she has PCOS. That's all that we know. And right now her sugars, once she delivered, the sugars went back to normal. So she's not diabetic right now, with the risk of having type 2 diabetes much later on with the PCOS. But otherwise, right now, she doesn't have any symptoms of diabetes. She's actually fine. The sugars are good on no treatment. The only thing she has is PCOS. Right now, I have not seen her. She's still breastfeeding. Her baby is she delivered in March this year. So the baby is about 7-8 months. She's still breastfeeding. So we don't know what her other problems will be in terms of just the PCOS when she wins her baby off. So she's also keen to know whether it's going to be of any benefit to try and go and remove that septum, or we just leave her alone.
So how are you going to manage it? Are you going to resect the septum?
I don't know if we'll lose anything by removing the septum, because it's really traumatic when she loses the pregnancy at 11 weeks. But I don't know if, I don't know what others think.
Sorry, I think maybe it's better to fix the other problems that we can now, like the diabetes, the PCOS, and try to optimize it for this pregnancy. And let's say try for another pregnancy. And maybe if then she loses, then you can decide to do the operation.
Okay, yeah, so right now she's not diabetic. She's fine. She's euglycemic. She's not even hypertensive. We took her off the BP medications. She's actually okay now. She has no problems except just the underlying PCOS.
Hello, hi, Dr. Marere.
Hello, Dr. Pfuma, how are you?
Fine, thank you. Sorry, I don't have much experience with this, but I just feel that if there is normal anatomy, because obviously the question which will be there, if you normalize the anatomy, isn't that more prudent? Because in the end, I don't think besides the reproductive failure, is there no increased risk of obviously incompetence of some sort, cervical incompetence at a later stage? Because obviously the anatomy is abnormal. So I don't know whether there's any literature to support any, I don't know, evidence-based approach to say, do you remove the septum and leave a sacrilege, or do you just put it like a sacrilege, as an emergency?
Yes. Oh, thank you, Dr. Vuma. So what I actually just came across was literature pertaining to a septum that's extending all the way. So if it's coming close to the cervix, then they'll lyse the septum and then do the sacrilege in the future pregnancy because of that risk, like you're mentioning, that they have a risk of cervical incompetence. And as you read the literature, they would all suggest that you'd probably better trying to make sure the anatomy is restored, because that will improve the implantation rates, reduce the recurrent pregnancy loss, reduce the rate of preterm labor even. But here in this case, it's just that she then had these other compounding factors which are confusing, because she didn't manage to carry through with lots of drama. Of course, she was unwell most of the pregnancy, but managed to carry through to 35 weeks. I'm sure if she had carried both twins, she would have lost both of them. So I think it was a good thing that we actually had the twin miscarry at 11 weeks, the other twin. So I keep telling that probably that's the only reason why she managed to progress to more than 34 weeks.
Thank you for that.
Just going around the room, Lesego, do you have any comment?
Hi, good evening.
Hi, Doc. How are you?
I'm well, thanks. How are you? Thanks for a very interesting and wonderfully laid out presentation. Sorry, there's one or two things that I missed, but I tend to agree with Dr. Vuma that if she intends to fall pregnant again, it's definitely worth restoring the normal anatomy and going to do the metroplasty. Yeah, but other than that, nothing else. Thanks for the wonderful presentation.
Thank you.
Hello, my name is Dr. Sanket Pisat. I am a consultant gynecological minimal access surgeon practicing in Mumbai, India. The initial 2.5 minutes of this video. Hello everyone. Today we will.
There was a video that it started showing Dr. Marere. While you are trying to connect it, perhaps Dr. Msupi can comment, followed by Dr. Manase.
Thank you so much, Dr. Marere, for that excellent presentation. I think considering all the other comments, no additional comments from me. Thank you.
Thank you.
Thank you for the presentation. I had a patient once was almost similar to that. And after I only saw after about 5-6 miscarriages, the stethoscope went on to fall pregnant again. And with the use of progesterone, she was able to deliver at a term, which was very nice. But yeah, it was an interesting presentation. Thank you.
Thank you. So you can see in that video, that's not the one I was showing. The one I was going to show was just the cold scissors. They're actually using energy. And you can see the forward movement towards the fundus using that electrode. So the good thing is that it actually doesn't bleed. So I don't know what the others' experiences have been with the septum or any post, any follow-ups post resection or incision of this septum.
Dr. Marera, I think you'll need to share the videos. We couldn't see them. Stanley, please go ahead.
All right, we'll share later.
No, sorry, Chibet was from last time. So let me drop it.
I think if there are no further comments, we can end the meeting. Dr. Marera, it was a really interesting presentation. I'm looking forward to the videos you share. Okay, someone is about to speak. Okay, go ahead.
Yeah, sorry that I don't know. Maybe I must have missed it, but I wanted to just make one more comment. With the MetroPlast, I don't know. Maybe I missed because I was on and off. That I've had experience with one or two, but the one didn't end up well. I think I ended up perforating the uterus because it was very difficult to see where to stop, and I was using scissor. Now the advice that I got, or the advice that they use that they talk about, is that when you use a scissor, it's important to stop where you see that the ostia are at the same level. 1, 2. Whenever bleeding starts, it means that you shouldn't go further than where you are, because the septum on its own shouldn't have any. Usually there's no bleeding when you cut the septum. So that's the little experience that I've had. I've unfortunately been into the perforated, and the first thing that happened was the loss of pressure on the water that we on the distending media that we're using, and then I then proceeded to do a laparoscopy and suture the defect from above. But yeah, she did well. But yeah, that's the little experience that I had with a similar case.
Thank you for sharing, Doc.
Thanks.
Thank you, Dr. Marere. Thank you, everyone. We'll reconvene next week. The recording will be available online.
Thank you, and sorry, apologies for the other half could not share. I'll just send it through to you, Chipo. Thank you so much. Good evening.
Thank you very much, Dr. Marere. Thank you, everyone. Thank you.
Good evening. Have a nice